I'd like to welcome you to our Stakeholder Reference Group session. This is our live Q&A, and this session covers the Green Book, the appraisal process, and the site review. My name is Louise Halfpenny, and I'm the Director of Communications. And just to run you through a quick agenda of what we'll be covering in this session. And first of all, I should also say welcome. You may have heard about this session from friends or colleagues or people who have an interest in this project. So if you've come to us via another route other than the SRG, then please can I say welcome, and please can I invite you to join the Stakeholder Reference Group. In doing this, you will receive emails, notifications of when we've put new content up on our website. It's not compulsory. We will, of course, listen to you if you are not a member of the SRG, but it does mean that we can do a better job of keeping you informed. So we're using Zoom for this session, and we ask that you send your questions to us via the chat function. We already have quite a stack of questions already, and we're going to start with those that have been submitted. And we are going to cover, as I said, the site review and also the Green Book. Now, we're not going to do a quick recap because hopefully you have already seen the slides, you've been following the progress, and you know roughly where we are. And I think more will come out as we do the answers. And because we anticipate quite a lot of questions, we didn't want to take up too much of time doing the recap. So the people that you have on this call today are Helen Brown, our Deputy Chief Executive, Dwayne Passman, Acute Redevelopment Programme Director, and Esther Moores, same job title. So we're all here ready to answer your questions. And the first question that I would like to start off with is one that's been submitted asking about planned care and how patients would be looked after if they were having some kind of planned care procedure but suddenly deteriorated or needed to be taken to an intensive care unit. So Esther, could I please ask you to come in on that question?
Sure, thank you, Louise. So I think the first point is that we would want, of course, to manage any risk to prevent that situation from occurring, as we do at the moment. So we have really clear protocols and procedures so that patients are really fully assessed, and we're really clear as to what procedures are appropriate on a planned care site. And that's something that our clinical teams are very used to managing, so that we can absolutely minimise the risk that anybody would need transfer as a result of procedure on a planned care site. We also are looking at the cover arrangements that we have. So we are always looking at what's appropriate. Are there other procedures that we could be doing on a planned care site that we don't currently do, that it would be advantageous for patients for us to add those to the list of procedures for that site, and looking at whether that means extra nursing cover, extra anaesthetic cover. But I think the final point is that in the event that somebody would need to be transferred, which would be extremely rare and is extremely rare with the St Albans site as we have at the moment, then of course we would always treat that as something that we would review very seriously, because then we want to learn the lessons and keep developing our best practice as to how we work. And there are other sites that, such as Swelliok for Epsom and St Helier, that are standalone planned care centres. So we're not alone in doing this, but it's all about making sure that we have robust clinical protocols, and it's very much a clinical decision so that we do the right things for each individual patient.
Thank you. And that leads me well into another question also about that neck of the woods, which is about the Epsom and St Helier public consultation. So there's some rather large changes happening in that part of London and Surrey. And the question is all about the documentation that has been provided for local people. and we have been asked if we could produce the similar, so a table in respect of all the long list options, and with all that level of detail. So I just wondered if we could go to Dwayne on that question about the level of detail that we've been asked to provide and the difference between consultation and engagement.
Certainly, thank you very much, Louise. I know I'm a new face to these meetings. I'm delighted to be joining Team West Herts. I've joined Team West Herts as the Acute Hospital Redevelopment Director, and I hope to meet some of you all, not only virtually, but in person in the near future. In terms of the documentation that came from Epsom St Helier, I think, correct me if I'm wrong, but I think the documentation looked at the detailed costs around the shortlist. I will review it again just to make sure that I'm not mistaken on that. What we have tried to do as part of the presentation that we gave to through the recording that was done for SRG to review last week is we presented all the capital costs indicatively for planned care options and emergency care options. But what I'm very, very happy to do is to review the presentation of that and see if there's a way in which we can do it more easily and more intuitively. But also, when it comes to the shortlisting phase, going from shortlist, long list to shortlist, shortlist to preferred option, between the shortlist and preferred option stage, we will publish in much more detail all the costs for each of the options.
Thank you, Dwayne. So confirmation there that once we get to the shortlist, the level of detail really steps up a notch. And if I can stick with you also, Dwayne, we've been asked a question about land sales. So if we were to go for a new site, can you give a figure on how much we would take from land sales to be able to contribute to that?
Indicatively, and hopefully SRG colleagues have been able to review our frequently asked questions on the Trust website. If not, please do. But indicatively, the land sale values that we have if we did move to a new site would be between 45 to 58 million. Now, we're firming those up at the moment, but that's the best range that we can give at the moment.
Thank you very much. Thank you. Helen, I think this next question is coming to you. It's quite long, but I'm going to do my best to summarise it. And it refers to the letter from the Department of Health and Social Care, in which they have mentioned 3 options that they expect to see on the shortlist. So to sum it up, the question really is saying, well, if we've been told to include the shortlist, what's the point of the stakeholder reference group and all the work that we're doing at the moment around the long list?
Okay, thank you.
Have a go answering, thank you.
Yeah, thank you, Louise. So the letter from regulators does set out 3 specific options that they would like us to include in our shortlist. And we have had a number of discussions with the regulators over the last several months, really since the announcement last September of the indicative 400 million for the redevelopment here. Effectively, our discussion with them then was, if there's any flexibility at all in the funding envelope available to us, then there are additional things that we could do that would improve the solution for our local, for our local people, for our patients. And in that discussion, we talked about a range of things. A relatively small increase to the funding envelope would enable us to include a new emergency department, to refurbish all of the beds within PMOK rather than just a proportion of them, which is what the 2019 SOC included, all the way up to new hospital, full new build on the Watford site or full new build on a new site. And clearly on that spectrum, there are a number of things that you could do, but there are also some kind of step changes, one of which is a decision about whether or not you retain the Princess Michael of Kent block on the Watford site, which is the largest single clinical building on the site. People will remember that in 2019, when we were working absolutely to the 350 million envelope, we couldn't afford to replace the PMOK within that level of funding. So one of the discussions we had with the regulators was, what would it take? What would the cost be of replacing PMOK, and what would the benefits be? Now, these were all high-level discussions. We did provide some costings. They were indicative at that stage, but it was, very positive for us that the Department of Health and NHS England came back and said, yes, we are willing for you to look at some of those options in your outline business case, even though that would require a significant increase in the level of funding available to the Trust. What it doesn't mean is that we can't consider other options, and what it doesn't mean is that this process we're going through now isn't really important. And we were very clear with the regulators when we were having discussions with them earlier in the year that we would need to do a proper long list to short list process, that we would need to be engaging with our stakeholders, that we would need to be transparent, and that the final solution that we come up with might not be one of those three options. And we continue to have that discussion with the department and NHS England about what the most appropriate options are for us to appraise on our shortlist. And that potentially includes all of the things that I've just described on that spectrum. So it is, I understand why people look at the letter from regulators and think, oh, that seems very specific, and it doesn't include full new build hospital options on it. But it's just one part of the discussion that we've had with them. And this process is absolutely going back a step to say, of all the options available to us, what would they look like, and what are the key things that we should take into consideration as we decide what to have on our short list of options. I'll just say one more thing on this issue, which is, and referring back to the Green Book, there are some things that you are expected to include within your shortlist. One of them is called the business as usual option. So that's the minimum capital spend to maintain your buildings and or develop any additional capacity that's required. You then have, and we've estimated that in the last SOC process for general sites, so for emergency care, at about £80 million, with about 70 million, I think, on the other sites. So let's call it 100 million plus or minus across all three sites as business as usual. You then have a do minimum option. And in its purest form, the do minimum is what's the minimum you could spend to deliver your investment objectives, or at the very least, the minimum you could spend to deliver your priority investment objectives. And I think the discussion, again, with the department and the regulators has been that they really expect our 2019 SOC preferred way forward, which was the 300 million for emergency care, to represent our do minimum option within the shortlist of options. From there, we can include 2, 3, potentially 4 other options on the shortlist. But the challenge is that you do a huge amount of detailed work at shortlist stage. So the process of going to long to shortlist is to genuinely determine the options that you think are most likely to deliver your objectives and be achievable and good value for money. So that's the process that we're going through now. Genuinely, the conversations with stakeholders are important to us. We talked in our presentation a bit about some of the changes we've made following the feedback last time. We think it's important that you understand the process that we're going through. We think it's important that we do share with you the conversations we're having with regulators, because this is not something that's happening in a vacuum. This work is important conversations with yourselves, but also important conversations with other stakeholders and regulators. So I think that's the best I can say. And I think the presentation and the explainer that we did last week showed you that range of options, and the long list generator and the appraisal process that we're going through, which will ultimately determine what we recommend in terms of our short list of options. and there will be opportunities for you to feed in your views on that as we proceed to a board decision in October.
Okay, lovely. Thank you, Helen. So not such a short list after all, is one point. And the other point is, yes, please continue to engage with us on this process. So the next question is one about transport, which I'm going to ask Dwayne and possibly Esther to answer. And it makes the point that the site survey doesn't really focus on travel options for the 4 other possible sites, and that there are public transport options in place for the Watford site. So you may wish to comment on that, but I think it's worth broadening out, Dwayne, on how we will look at transport and when that will happen. So if I can ask you to start with that, thank you.
Thank you very much, Louise. It would be usual at the shortlist stage to do a full traffic impact assessment and transport impact assessment for each of the shortlisted options. So bearing in mind what Helen has just said, in terms of what we end up with as the shortlist, then we will undertake a detailed exercise at shortlisting stage around transport assessment and transport options for each of the shortlisted sites.
Can I come in?
Esther? Yes, please.
Yeah, thank you. So the only thing that I would add to what Dwayne's said is that it is difficult to make fair comparisons between existing hospital sites and the transport infrastructure that they've got and potential new sites which are clearly not set up currently to support the range of services that are delivered by a hospital. I think the site review team are giving a quick look to some of the infrastructure issues related to the new sites, but our working assumption would be, particularly for bus routes, I mean train routes obviously more difficult, roads and buses, we would need to look at what we would do to improve or ensure good access to sites. The same is true for our existing hospital sites. There are improvements. We know there are some difficulties with public transport access to existing sites. So we've got a commitment to keep looking at how we can make it as easy as possible for people to access our services, as well as, and I'm sure Esther would come in and say this from a clinical perspective, trying to reduce the number of times that people need to come to hospital, trying to make the use of things like Zoom to reduce that, and to do much more one-stop delivery models, so that if you need to go to St Albans for an outpatient appointment and diagnostics, we can coordinate that onto one day. So I think Dwayne's point is absolutely right. The key focus on looking at different options and the pros and cons from an access point of view will come at shortlist stage. One of the trouble with me having so much history now here is I can also say that we did do quite a lot of work on transport and access back in 2017 when we were looking at options, and the truth is that when you look at where services are provided, some people live nearer to hospitals, some people live further away. If you change where they're provided, that changes, but actually the overall accessibility doesn't change that much when you take into account the whole population of accessing services. So again, it's quite detailed and complex and will be done in more detail at shortlist stage.
Thank you. So sticking with you, Helen, can I ask you, this is probably the $1 million question. So is it feasible to meet these timescales, and is there going to be a final sort of go, no-go decision?
Yeah.
Thank you.
So the timescale, the HIP1 programme has got an ambitious timeline, and that is set by the government and by the Prime Minister personally, who's very keen to see rapid progress with improvements to hospital services. And our conversations with regulators always touch on what is the timeline that we can deliver to, and what is achievable, but also what is realistic. I mean, 2025 is quite a tough timeline, and we've said to regulators that everything would have to go absolutely smoothly for us to get, and you know, to achieve timeline, and we talked to them about 25, 26, and that's what we've reflected into our critical success factors, essential criteria and investment objectives. So I think 2026 is probably more realistic, but we are absolutely working to do this as quickly as we can. I think it's important to say, because although I've emphasised the kind of government's perspective and the HIT1 programme target and ambition for timelines, it's also important to say that our trust board, our clinical, our clinicians are really keen to see us make progress with this, because we know that our current buildings and infrastructure are not helping us deliver the best possible care. And we also know that there is a risk that some of our infrastructure could fail over the next few years. So we do think that it's important we choose an option or option. When we get to preferred option, we want to be confident that we can deliver that to the fastest possible achievable timeline. Now, I've just seen a little pop-up from Steve at Herts Valley Hospital saying, you know, have regulators accepted a slip to 2026? And that brings me on to my next point around this, is this is not, you know, there is no absolute go, no go on this scheme related to timeline, but it is a really important factor. And we need to be realistic. We don't want to promise to do something quicker than we can, but equally, we do want to choose something that we believe we can deliver within that kind of 5-year time frame, or as close to it as we possibly can. And the case I make to regulators again is they're very keen to see things deliver as quickly as possible, and that was part of the factor that they took into account, I think, when they chose which hospitals to go into HIT1. But the case for investment in West Hertfordshire doesn't go away if we can't meet 2025. So Steve, no, they haven't accepted a slip, but this is an ongoing dialogue with them about what is achievable, what it's going to take, how we can get there, how we can keep progress going. And we've always said to them 2025, 2026. They've agreed our investment objectives, but the kind of impetus is still there to deliver to 2025 if we possibly can. I'm going to draw a line under that one.
Thank you, Helen. Well, we can give you a breather, because I think the next one is a Dwayne question, and it's about the site survey, or maybe Esther, you might want to contribute also, saying that it would be really helpful to show on a map where each of the sites are to be, where each site that's being looked at is. Is that something that we could do, Dwayne?
Certainly. The new site survey report is due this week to be with us at the Trust. Hopefully people will recognise, as I said at the beginning of this process, this is the beginning of week 4 for me. So I'm as keen as anyone else to see the distribution of sites and exactly where they are, because I don't have that history. It will be in the report. If it isn't directly in the report, we'll provide a summary map of where all the sites are. So absolutely, yes.
Great, thank you very much. And Esther, possibly one for you, if you know this. There's a question about the Radlett Aerodrome. Do we know yet whether that has been confirmed as a rail freight terminal? Because that was one of the sites that we're looking at.
I'm afraid I don't know the answer to that, but I'm looking in Helen's direction, that she might have more recent information on that than I do.
So I don't have the definitive answer to that. My understanding is that the Radlett Aerodrome site is quite large, and that whilst there may still be active plans for a rail freight terminal there, it wouldn't necessarily preclude also developing a hospital on that site. But what I will say is absolutely the site review, which we are expecting to receive by the end of this week, and we'll put into the public domain early next week at the latest, I very much hope, will definitively get the latest position based on their conversations with planners about whether that site is is available for development. My understanding is it potentially still would be if we thought it was a good site, accessible and deliverable within a realistic timeline.
Thank you. And Helen, can I ask you a question about car parking and the new car park? Are there going to be fewer spaces in the new multi-storey car park than we have currently available? And if so, why, please?
Okay, so the quick answer to this is that the overall car parking for the Watford site will increase, not decrease, when we build the multi-storey car park. But the multi-storey car park itself won't have as many spaces in it as we have in total currently on the Watford site. And that is because it is intended to keep some surface car parking alongside the multi-storey car park. So overall, and I think we do need to update our frequently asked question on this because I had a quick look at it before we came onto the call and I don't think it's quite accurately reflecting the position. We will see an increase in spaces for the hospital. The balance between what goes into the multi-storey car park and what we have surface car parking will develop over time. And actually we need to develop a green travel plan and try and reduce the number of car journeys to the site to contribute to a kind of sustainable future. So I would hope that over time we will be able to reduce the total number of car parking spaces as we deliver our care differently, we reduce the number of outpatient appointments on this site, and we think about other ways for people to access. But we've got more spaces, not less, as we build the multi-storey car park.
Okay, thank you. Dwayne, can I just come back to you with another question on the Epsom and St Helier plan and the provision of detail as we get into the shortlist stage? Will the costs show things like maintenance and refurbishment costs? Because obviously if you're looking at the Watford site, the costs of refurb are higher. And the questioner really wants to know that we take that into account when we make a comparison between that and a new site.
That's absolutely the case. Whether it's a new hospital on the Watford site or somewhere else, those are absolutely the things that we need to put into all the costings that we look at shortlist stage to help us select a preferred option. So maintenance costs, backlog maintenance costs, how the hospital operates and what that means for clinical staff time and support staff time in operating a hospital that's either dispersed or more compact will absolutely form part of our shortlist deliberations to moving us towards a preferred option. And I hope that answers the question.
Thank you very much. Helen, possibly one for you coming up about teaching hospital status, which is something that we talked about in our FAQs, not quite related, but I suppose kind of in terms of recruitment, because the questioner is asking us how we think that would affect us in terms of our recruitment if we become a teaching trust.
Yes, so it's providing a good environment for learners is really important to us, and actually we believe currently we're quite strong in terms of our medical training and our links with the Middlesex University for nurse training and the range of opportunities that we give. Having a teaching trust kind of status is helpful for us in terms of communication, particularly for attracting new staff, but we are constantly looking at how we can develop and improve our offer to our staff in terms of learning and development. And actually in some ways the change between where we are now and where we will be when we get a teaching in our label in reality won't be that huge, but it will be a clear kind of statement of our commitment to learning and the support that we offer. I'm going to give you one example, is that we consistently get really positive feedback from our medical students about the experience that they have at Watford. I can't remember the name of the prize, Louise might actually remember it, but we have run a couple of years in a row awards for being a good place for our medical students to come. And the other thing I will say is that we're absolutely, as we start thinking about design for new hospital facilities, regardless of which site and regardless of which option, we're absolutely looking at how we can make sure we've got the best possible learning environment for our staff, because ultimately that is good for our patients.
Thank you, Helen. Thank you. Here's one that I can answer, which I can't always say that. Can we have the presentation without the video? So that is a reminder that after the sessions, we do make the presentations available. So if you're not familiar with our website, please do take a look, because we will be posting this presentation, and do keep checking back, because we are trying to give you as much information as we can as and when we get it. Esther, I'm going to ask you a quick question about parking, everybody's favourite topic, but in light of the information we've heard about building a new multi-storey car park, are we going to lose any spaces in the interim while we're waiting for the new car park to come into being? Is that something you know anything about?
Yeah, I don't know the numbers off the top of my head, but we can verify that. I think inevitably, as we are doing works, we will be losing some car parking space, but that we know we've been quite familiar with that over recent years as we've needed to do works and to survey for the work. So we're hopeful that we will be able to do as much as we can to minimise the impact of that, and also, you know, things we have done previously to try to minimise the impact is to look at where we can ask staff to think about car shares and other alternatives. So there were a range of things that we could do to minimise the impact as and when we might need to lose some spaces for the works to commence.
Okay, thank you very much. And just wanted to have a look through the questions again, and there is one about the voluntary sector and whether we will look to involve the voluntary sector. We do have some volunteer drivers. Would we be hoping to replicate that or keep that going between the sites? Helen, is that something that you know anything about?
I don't know specifically, Louise, around volunteer drivers between sites, but absolutely yes, working with a whole range of partners to deliver the best possible care is key to how we want to work and continue to work. So our volunteering is a really strong part of the hospitals. We did see, obviously with COVID, a number of things changed. Some of our volunteers were not able to come into the hospitals, but we did see people who were furloughed come and do a lot of work with us. We've built some really strong community links through the last 6 months. It's really kind of stepped up a gear as people have kind of rallied round to support the NHS, and we would absolutely want to see that continue. The Integrated Care Partnership for West Hertfordshire, which is all of the NHS and social care providers working together, have got a work stream and some developing thoughts about how we can strengthen our relationship with the whole range of community and third sector providers. So yes, in big picture terms, that specific issue I can't answer. The only thing I would say about inter-site transport is when we have tried to do it and offered it, the take-up is actually very low. So it isn't a very cost-effective model to have it running kind of permanently. It's actually more cost-effective, particularly if it's staffed to support ad hoc taxi journeys, and we have got a range of options for supporting patients to visit our sites if they are not able to access through public or private transport. So it does come up from time to time, this issue about inter-site transport, but our experience has been that there are not enough volumes to make it easy to sustain a service, even if it's voluntary. But talking about dial-a-ride or more flexible ways of doing that would be something we could pick up in our transport group, access group, when that gets established a little bit later down the track.
Thank you. Okay, Esther, as the longest serving by quite some way, member of the panel here today, I'm coming to you with a question about a survey on land sales dating back to 2015, and it was the KPMG survey, and I think that in that study it gave a figure in excess of £100 million, and we heard the figure was much lower that Dwayne gave earlier. Do you have any insight into why those figures are so different, please?
I can see that Helen had her hand.
I did.
Oh, sorry, Helen.
I wasn't so closely involved in this particular one, so I think Helen's probably best placed.
Yeah, so I believe that those numbers, I'm not sure it was KPMG actually, I think it might have been Deloitte, because I think, I may be wrong, I think this was connected to the Your Care, Your Future piece of work that was led by the CCG, but with inputs from all of, again, the local NHS and social care providers around developing the system strategy. And I believe that they were supported by Deloitte, and that Deloitte did a high level view of the finances of any changes that would be made, and they put some estimates in. I will just say, you know, that those estimates may have been higher. We have looked at this a couple of times, and again, as part of the site review, we have commissioned Royal Free and Montague Evans to give us a definitive professional view on the likely sale values of the sites now. What they might have been in 2015, the world changes, the economic environment changes, so we think we will have the most up-to-date, reliable view on values of land receipts from the site, this piece of work that we're expecting in the next week or so.
Thank you. And Helen, sticking with you, can I ask you about new site options, so clear site options? Will we be in the long list looking at an option of an emergency care hospital only without planned care? Do you know if that's going to be on the long list?
So on the long list, it absolutely is. And you know, there are so many different combinations of things that we could do, and we have looked at this in both 2017 and in 2019. Ultimately, you can have emergency care and planned care can sit on separate sites, or they can be co-located. I think the question here is to make sure that we're making fair comparisons, and I think that this may be where some of the question is coming from. So what we absolutely promise we won't be doing is saying, well, the cost of redeveloping emergency care at Watford is X, and the cost of building a whole new hospital with all of emergency care and planned care is Y, and therefore we can't afford Y, so we'll have to do X, because that wouldn't be a fair comparison. What we will be able to do is to say the cost of emergency care on a new site compared to the cost of emergency care on the Watford site, and there are different versions of that, and compare those. Having said which, if you were looking at a new hospital site, and if you were looking longer term, and if you were in a more central location, you might well want to look at incorporating planned care in, and the economic benefits of that might outweigh the capital cost. So the way we're treating that is to say, emergency care is our immediate absolute priority. We need to be clear what the best solution is for emergency care. We do need to make some investment in planned care now to make sure that that is sustainable for the next period. And I think we've put 15 years into our investment objectives and critical success factors. We do expect that we will need to look again in that time period to say what is the most sustainable, best long-term solution for planned care, in which case we could revisit, is it still retaining the Hemel Hempstead and St Albans site? Is it consolidating into a single site that we talked about in 2019, or is it potentially co-locating it with emergency care? So I know I've given a long answer to what felt like a short question, but it is quite complicated. There are so many different variations. The thing I give my absolute commitment to is that we are doing our best to make fair comparisons and also to get to the best solution that we can in the context of all the different factors and constraints that we've got to take into account.
Thank you, Helen. And there is a question that was submitted in writing earlier, which touches on the planned and the emergency care and the difference that we've set in time span. So the question says, if you are planning to cater for capacity until 2035 with a 30-year life, are you expecting to have to add to the build 10 years after its completion? And if so, how would this be achieved physically and financially?
So I'll pick up the first half of this question, and then I might ask Dwayne to pick up the second half of the question around flexibility and design. So modelling forward future demand for hospital services is quite a complex and difficult thing to do, but there is an established methodology, and again, every hospital redevelopment will work through this to say, what population growth are we expecting? What growth in services are we expecting related to things that aren't directly related to the population, but to advances in treatment or aging, you know, different health needs profiles changing over time. And then you set that next to, alongside that, well, what changes do we see in how care might get delivered? It's a shame we haven't got a clinician on the panel because they'd probably give a better, more recent clinical example. But for example, we know that treatments for heart attacks and strokes have changed enormously over 10 years, 15 years, and that has completely changed the profile of patients presenting from hospital. A range of preventative measures in primary care, different treatments, but also very different acute treatments available, has completely changed the profile. So we're doing our best to make to look forward and say, what activity do we expect to have to manage in the future? We're projecting forward to 2035, as I've just described, demographic growth, non-demographic growth, changes in service provision. We're talking to clinicians about what they see on the horizon. We're sharing our thinking with other hospitals going through this process, and we're coming up with our best estimate of future demand to 2035. If you try to go too much ahead of that, you are just speculating, and it's very hard. By building to 2035, the day the hospital opens, it will be bigger than it needs to be because we will have left some room for growth. But you can't afford, and it's not sensible to build it so much bigger that you're rattling around in it, or you've got unused space, because that's expensive and not going to be a possibility. So 2035, again, we're in discussion with regulators. We're comparing with other areas to see where they're setting that line. Effectively, we will keep it under review, and we do need to make sure we've got a flexible design. So this is the point I'm going to hand over to Dwayne, who can talk you through some of how we manage this and his experience elsewhere.
Thank you very much, Helen. I think it's worth reflecting very, very quickly that I remember in the late 1990s, quite a serious academic paper was written by a researcher called Vetter, and he looked at the long-term trend on use of inpatient beds in the NHS. And in that analysis, he found that the last inpatient bed would close in 2035, having had a throughput of 24 million patients. So you can look at those sort of trends and make that sort of trend analysis, but it actually ignores what life and reality is about. And as Helen said, looking even 5 to 10 years beyond is quite a speculative business, because things can change so quickly in that 10, 15, 20 year planning horizon that we might not even understand now. And I think I'd give a couple of examples on that. We look in the 1990s at the amount of day case surgery that was undertaken in acute hospitals. And broadly speaking, it was about 50% of all the available operations that could be done were done as day surgery. Now we're up across the NHS to 80–90%. And in the 1990s, everyone thought that was just completely off the planet in terms of what was achievable. So as well as that, we look at outpatient appointments and the increase in technology from video conferencing like this, from Zoom and other applications. That means that people who would have had to go to a hospital site no longer necessarily have to, unless they require a direct examination. So I'm under no doubt that we will see things happen in the next 15, 20 years that will change the scope and scale of the acute hospital estate and the community and primary care hospital estate. But the key thing that we need to do as we're planning the new hospital, as Helen said, is to make sure that we've got some extra capacity there. And most of the hospitals I've been involved in planning over the last 20 years have had that extra capacity there to take account of natural growth that won't usually change because of different technology. But also that when we look at the planning of the site, we have the capacity in that master planning of the site to look at how we can change according to future demand beyond the planning horizon of 2035. So part of the discussion we'll be having going from shortlist to preferred option will be how those different options can react to change over time.
Thank you. And talking about the long list, we've been asked when we think that the final long list will be available for everyone to see. Helen's mentioned it's going to have quite a few permutations. Helen, could I ask you if you have a rough date for when we would have the long list from which we're going to make the shortlisting decisions from?
I'll try, Louise, but this is difficult, and particularly for people who have been involved in the past. The long list generator approach that we talked through in the slides last week is a slightly different approach to the approach that we've used previously, but it is the approach set out in the Green Book, and it is the approach that the regulators have advised us to use. So effectively, we use that long list generator to look at the absolute full range of options available to us. That is much bigger than just which site it is, what's the scope, what's the lifespan, what's the level of ambition, what's the delivery model, what's the funding source. So that long list generator considers all of those things. We then go through a process to say, of all of those dimensions, which ones do we think are most likely to support us to deliver? And then from that, you can start to generate detailed estate kind of solutions and options. So our best, are the slides that we sent out last week, which showed you a spectrum from 1 to 7, I think, of options. Even that isn't, that's a simplification, because on that spectrum there are potentially lots more. We are not intending at this stage to define that further. The next thing we do is to use the long list generator and appraise those dimensions to then say, okay, your short list of options will sit within these parameters, and then we can start defining. I think the tricky bit, and this is the bit that the programme team here have spent some time kind of sitting down and working through, is particularly when you're looking at options on the Watford site, it is actually relatively straightforward to define what a new hospital might look like, whether that's on the Watford site or another site. It's much more complicated actually and tricky to start defining on the Watford site between the 2019 300 million option all the way up to a complete new build. What are the sensible points on that spectrum to appraise in more detail? And Esther is working really closely with the clinicians to understand their views on the clinical models, the things that need to sit next to each other. Dwayne and the estates is working with the estates workstream to really look at the infrastructure on the site, the individual buildings, some of the non-clinical services and how they relate. And actually think that work will be ongoing for a period as we then seek to define some specific options onto the shortlist we would appraise. So I'm just trying to hopefully explain to people that it's never going to be, we've got these 7 options and we're appraising those 7 options to get to the shortlist. It is a more it's a more developmental or kind of iterative process than that, to start narrowing down to get to where you think you need to concentrate your efforts.
Thank you. And can I ask a follow-up question? Because it is different this time, isn't it? This year round, it is a different process. And last year or previously, people will be thinking, perhaps those who followed this through, of papers with all of these options neatly numbered. And obviously it's a little bit different this time. Either Helen or Dwayne, could you share with us how we or members of the stakeholder group will get a sense of all of those things that are being discussed as we move from long list to short list? How do we share our thinking around those?
So I'll start and then Dwayne can come in. So we did share last week the long list generator kind of framework, which explained under the 5 headings that the Green Book requires us to look at, how we've interpreted those locally in a West Herts context and what dimensions we will then be looking at. The next thing that happens with that is, well, currently the programme team are collecting a range of evidence that will then support us to assess those domains. And what we will do is the intention is to do that piece of work as a programme team, but with input from the regional strategic estates team and from Health Watch Hertfordshire, to do an initial scoring of the long list generator to help us define both our preferred way forward, which we're expected to do at this point as well, but also options that dimensions that we think meet our criteria but are potentially not the preferred way forward. When we've done that piece of work, that gives us a much clearer place to say, from that, this then looks like the short list of options that we should take forward. And what I think we said in the explainer last week, and certainly our current thinking, is that we should be in a position to share that by the 2nd week of September, so that stakeholder reference group, professional reference group, other stakeholders can see all of that work, can feed in their comments, and as we finalise the recommendation to board, that can be taken into account. And the commitment that we've made in the past that we retain is that we will always make sure that the board, both our board and the Herts Valley CCG board, are completely aware of the full range of views that get expressed to us over that period.
Thank you. And Dwayne, perhaps I could come to you, so, if you've got anything to add, and just to confirm where we will be making the decision, sort of in what forum we'll be making that long list to short list decision public, so people can hear about it.
Certainly, just to add to what Helen said, the Green Book gives us a set of tools and techniques that have been well developed over 40 years now in the public sector. And it's not just health, it's across the whole of government that needs to use that framework. And what it allows us to do is to have a relatively objective, transparent, but also rational process. So we take the emotion out of the process, and it's a very rational process to arrive at a shortlist, and then beyond that, and there's a whole other process that goes beyond that, detailed working to get to a preferred option. But at the moment, as Helen said, our timescale is to publish what we think the shortlist is going to be based on that analysis in September. And there will be a joint board between Herts Valley CCG and West Hertfordshire Hospitals, I believe on the 1st of October, to discuss and ratify that in detail, taking on board, again, as Helen has said, and as we said in the presentation last week, all the comments that we've had from all stakeholders, so that those decisions are being made in the full knowledge of all the discussions that are going on around us in a transparent way.
Thank you, thank you. And there were another couple of questions which are probably too long, so they're for us to sort of deal with here. So I think a tip and a plea is if you could send in questions that are relatively short, that will really help us summarise and ask them. We will bundle all of these questions up, all the questions we've been asked on the session, all the questions that have previously been sent to us, and we will put them all in the FAQ. We're already working on the next version, and that will come out to you. We would also like to remind you, if you are new to this session and you're not yet a member of the Stakeholder Reference Group, please join up. That way we can keep you updated. That would be great for us and hopefully interesting to you. Please continue to look on the website. And for now, as we have no other questions that have just come in the last couple of minutes, I'd like to thank the panel, and I'd like to thank you all for giving up your time on this very hot and sticky day. Thank you very much.